This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, and thank you for joining us today for our HealthyU webinar series. Today's webinar is all about acid reflux. At any time during the presentation, feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous as always. Today's presenter is Dr. Arif Ahmad. Dr. Ahmad is recognized as one of the country's top bariatric surgeons. He is a board-certified surgeon with extensive fellowship training in advanced laparoscopic surgery, including bariatric surgery. He specializes in all areas of bariatric surgery, including laparoscopic sleeve gastrectomy, gastric bypass, gastric banding, revisional bariatric surgery, and others. He is an expert in minimally invasive surgery using small incisions that result in minimal pain, less scarring, and shorter recovery. He has completed fellowships in the U.S. and the United Kingdom, including the Fellowship of the Royal College of Surgeons, an advanced training fellowship at Harvard Medical School, and a 5-year residency at the University of Connecticut, and an advanced laparoscopic surgery fellowship at the University of Virginia. He has taught other doctors how to perform bariatric surgery at Stony Brook University and was a founder of the Department of Bariatric Surgery at Mather Hospital. He is also the director of the Robotic Center of Excellence at Mather Hospital, Northwell Health.
So in addition to what Emily just said, I wanted to just point out that, I also specialize in all forms of minimally invasive surgery, not just bariatric surgery. So, my extensive training has been in minimally invasive surgery, which involves robotic surgery, as well as, surgery for acid reflux. So this is actually a pet topic for me because it's one of my great interests is treating people with acid reflux. And they're some of my most grateful patients when they have long-standing acid reflux and I operate on them and then the reflux goes away. So now that we have the advent of the robot, the reflux surgery is a lot, there have been advances in acid reflux surgery. We're still doing the same procedures. Thank you, that's wonderful. We're still doing the same procedures, but we can do them with a lot more ease and precision when we do it robotically. So some people think it's just a touch of heartburn, so to say, but really for most people, it's a major problem, acid reflux, if it's severe, because it really affects patients' quality of life and in some cases, even their duration of life.
Emily, can you see the screen?
Yes.
Okay, so then there's the quality of life impact. It affects people's quality of sleep, reduced work productivity. They cannot eat various different kinds of foods, and there's concern about the long-term effects of gastroesophageal reflux. And for many patients, it's a lifelong dependence on medication, which by itself is problematic. About 10 to 15% of adults suffer from acid reflux daily. So it's a big problem. The incidence rises after the age of 40 years of age. And for most patients, acid reflux gets worse over time. And early correction of the problem can prevent further deterioration of the natural barrier to reflux. So what causes acid reflux? So normally there's a valve at the lower end of the esophagus, which is the food tube. And this valve prevents acid from the stomach. Stomach is where the acid is made. And the valve prevents the acid from going back into the food tube or the esophagus. So when this valve isn't working, then people have acid reflux. Sometimes it's not working because it's weak. And at other times, it's not working because from time to time, it just relaxes without a good reason. Now, long-standing acid reflux can cause a lot of problems, like esophagitis with stricture and Barrett's esophagus. Barrett's esophagus is a condition where there's a change in the lining of the esophagus so that it becomes, thank you, that's much better. So that it becomes a lot more like the mucosa or the lining of the stomach, and those are precancerous. This is just a diagram to show you the angle of His, we call it, which is the angle where, the most of these things occur. So it's the angle between the fundus of the stomach, which is part of the stomach, and the esophagus or the food tube. This should be at an angle to prevent acid from refluxing up. When it's not at an angle, then the acid is more easily goes up into the esophagus. This is the first picture. It just shows you how this normal angle and this valve works. And the second picture is when we do an endoscopy, we can see this fold here. This fold is actually helping to form this valve or barrier. And why does it weaken? Well, we're not exactly sure. Sometimes it's associated with a hiatal hernia. Sometimes it gets weak over time in some patients, and it's more common for patients with a family history of this condition to have a weaker valve. So what's a hiatal hernia? A hiatal hernia is where part of the stomach is pushing into the chest. You can see the first picture shows the normal anatomy, and the second picture shows where part of the stomach has pushed into the chest above the diaphragm. Emily, can you guys see my arrow?
Yes, I can.
Okay, great. So the arrow points that I'm using now points the diaphragm, and then the stomach is going up. You see, normally in the first picture, you see only the food tube is above the diaphragm. And it's often associated with obesity, reflux, acid reflux, and it suddenly gets worse with obesity, because obesity causes a hiatal hernia because of the increased pressure in the abdomen. It causes part of the stomach to push into the chest. We can't say it causes it, but it predisposes to it. And then increased pressure within the stomach also makes the acid go up. It exceeds the pressure of the valve. And then, also it can cause delayed gastric emptying, which can, obesity can cause these things. And it's more often associated with motility problems of the esophagus, which means movement. So how do we treat gastroesophageal reflux or heartburn? Now, you all know that, most people are treating these conditions, many of them, depending on how severe it is, many people are just treating them at home with, acid reflux medicines. Sometimes you can get just Tums, or you could get, omeprazole, which is over the counter, or you could go see your gastroenterologist. But the important point here is that managing the symptoms is not treating a disease, you see. For example, a headache is a symptom of a disease. Now, if you don't find any cause for the headache, then you can take medicines for it. But suppose headache is a sign of a brain tumor. You don't want to just mask the headache, the tumor, by just taking medicines, So you don't want to mask the symptoms, but you want to understand where the symptoms are coming from. So if the symptoms are persistent and prolonged, then it's good to see someone who can understand this better and doesn't just give you something to mask the symptoms. As you know, as we mentioned before, 1 in 5 people suffer from GERD, and more than 21 million people in the United States are on proton pump inhibitors, which is the medication that basically just, you're still refluxing, but you're not feeling it as much because its acid is low in acid. And that's not the best way to treat the problem, because the problem of acid reflux is just a symptom of the problem. No point masking the symptom. And in spite of all this, 10 to 15% of people will develop Barrett's esophagus, which has an 8-fold increase of chance of getting esophageal cancer. So those are some of the symptoms: heartburn, sore throat, regurgitation, cough, difficulty swallowing, shortness of breath, dental erosion, the enamel of the teeth gets eroded, and bad breath, and associated with chest pain and asthma. Even patients who think they just have asthma, many of them actually have acid reflux, which is making the acid go into the lungs, and it's triggering an attack of asthma. I have many patients that after I fix their acid reflux, they don't take asthma medication anymore. And it's similar with the sore throat. These are called extraesophageal symptoms. That means they're not coming from the food tube or the esophagus itself, but when the acid goes to other areas, like when it goes to the larynx, it causes sore throat. When it goes into the lungs, it causes cough and can cause shortness of breath and chest pain and asthma. And and this just shows that, you know, the abnormal pH can be reduced by using medication, but people are still refluxing. That means things are still going out. Of course, there are other forms of managing this, and you know, that's diet modification. You could eat different foods that are less likely to reduce the pressure on your sphincter of the lower esophagus, like caffeine and chocolate and alcohol and tomato-based foods. They're more likely to reduce the pressure within the sphincter. So when the pressure goes down, then the acid tends to come up. And then there are things like, you know, not eating fatty food and things like that, oily stuff, increasing the head end of the pillow. These are just ways to symptomatic control the acid from coming up. And then there are medications. Like I mentioned, all these medications just block the symptom of acid reflux. They don't prevent the regurgitation. And I think we have an hour, right?
Yeah.
Total? Okay. So in spite of the medication, we find about 62% of people still have symptoms, and 30, you know, and many of them are really, more than about 40% of people have what we call breakthrough symptoms. And if you look at how often these people are getting these symptoms, 5 times or more per week, you can see on the second chart here, 65% of people are getting it, you know, in spite of all these medications. And more, the medications are coming under scrutiny, more and more as we understand. You know, when we first, if you look at the literature on these medications, you'll see, if you look at the insert, you know, which is the package insert, which says instructions for use, or, you know, it tells you you can't use it for more than 6 weeks. But everybody knows that if you have acid reflux, you're going to use it for the rest of your life if you're going to depend on medication for it. And when you use something long-term like that, then it's associated with a number of side effects. We know that it increases osteoporosis and can cause fracture risk, especially as patients get older, because the bones already become thinner over time. These are some of the FDA alerts. You know, low magnesium levels can be associated with long-term use of proton pump inhibitors, and low magnesium levels have effects on the heart and the cardiovascular system and blood pressure. So a lot of the patients, you'll find they're also on blood pressure medication. They're on so many other things, you know, but some of these could be related to. Also, now it's become a big problem is C. diff infection. This is a big problem in the hospital, especially because we've been using proton pump inhibitors on almost everybody that we're doing surgeries on to suppress the acid. But as we suppress the acid, this bacteria called Clostridium difficile, it finds a place to live in the stomach and the gastrointestinal tract. And therefore, patients who are on proton pump inhibitors are more likely to get C. diff, which is a serious problem. It can also be fatal. Not that it always is, but it can be fatal, and it can be a big problem. So more and more the hospitals are looking at how to prevent these things from happening. Also, there are reports, you know, published in various journals about increased incidence of kidney failure, increased incidence of heart failure, as well as dementia. Now, I'm not saying that patients should never take proton pump inhibitors. I think that there is a place for them. But what I do think is that every patient who suffers from acid reflux should understand that acid reflux is not being treated by the medication. It's just being suppressed, and you're still regurgitating. And long-term use of medication is associated with a number of problems. So they should all be aware of that as they weigh that against the possibility of minimally invasive surgery to cure the problem. Medications, so they do not address the reflux barrier. Oh, this thing. All right.
They can't see that.
They can't see that. Good. Okay, good. So that just shows you how you're still refluxing even with the PPI. See, on PPIs, they're still refluxing. The reflux is the same. It's a question of how acidic the reflux is. And this is a Gallup poll, and 72% of people on medication, 79% still had nighttime symptoms. 50% still had reflux and all these other things. And 20 to 40% of people are dissatisfied with their medication. So how do we assess somebody? How do we work somebody up who has acid reflux? We do it under upper endoscopy. We do a barium swallow. We do pH monitoring as well as manometry. We do these last two, which would be number 3 and number 4, and also number 2. We do these 3 only if we are going to be operating on you. And maybe that, mostly we don't even need the barium swallow. So we just stay with the upper endoscopy, pH monitoring, and manometry. But even people who are not having surgery should undergo an upper endoscopy if it's long-standing reflux, because we want to make sure that nothing bad is going on. So this is an endoscopy here, which shows that the lining of the stomach has moved into the esophagus. You see that, how that thing is like an irregular lining there? That is called Barrett's esophagus, which is precancerous. So patients with that condition would not know that they have it. They'd just be having long-standing acid reflux, but they wouldn't know that they need to be kept a close eye on because this could become malignant. This one is an upper GI, which says where you swallow something and we see how it's going down. This one here is a manometry study to see how the esophagus is contracting, and this one is a similar motility test, as we call it, And so there's really a gradation in clinical findings. There's physiological reflux. That means everyone refluxes once or twice a day, but it doesn't really cause any significant symptoms. Then there's symptomatic GERD, which means gastroesophageal reflux, giving patients symptoms. Typical symptoms are heartburn and regurgitation, and atypical symptoms are chest pain, asthma, sore throat, cough, things like that. And then over time, the complications develop, like ulceration of the lesions, bleeding from those lesions, and then long-standing acid reflux can cause that part to narrow down and form a stricture, which means a narrowing in that area, which then makes the food often get stuck in that area. And then Barrett's, which means the lining has changed, and then it predisposes to adenocarcinoma, which is cancer. So this just shows you some of the stages. So this is esophagitis, where there's just inflammation. We see this on endoscopy. And this shows you that the scarring has started to progress, forming a stricture. And then over time, the chronic exposure can cause the lining to change, like it shows you here. And that causes Barrett's esophagus, which has a much higher risk of getting cancer. And this is an example of esophageal cancer seen on endoscopy. You can see how this area is red. This area is all like, inflamed looking and elevated. And this part is just Barrett's esophagus. So this has happened on top of Barrett's esophagus. So what we would do in this situation is we would biopsy it, and if it showed cancer, then we'd have to operate on this patient, provided the cancer hasn't spread already. And in fact, esophageal cancer has increased 600% since 1975 to 2000. If you see that, that's a 600% increase. And that red line there is the esophageal cancer, and all the other colors, melanoma is like orange, and prostate cancer is what do you call that, blue or teal or something like that. And then the breast cancer is green, and the lung cancer is yellow. So you can see those have kind of stayed reasonably the same. Melanoma has increased, and prostate cancer has increased, but more recently has done better. But you can see that esophageal adenocarcinoma has increased 600-fold. And this is often associated with acid reflux that's just being treated with proton pump inhibitors or not treated at all. So if you have acid reflux, really, I think that patients should be assessed not just by a gastroenterologist who doesn't operate, because they're not aware of the options that are available to these patients, but also by a surgeon who's interested in surgery for acid reflux, so they can get their options clear, But basically your options are, you either take the medicine for the rest of your life, okay? And you will still have nighttime symptoms, and you will still reflux because you won't feel it as much, but things will still come up. That's called regurgitation. And if you're happy with that, then that's one option. And then the other option is to undergo minimally invasive surgery, which is something we do with the small holes. It takes about 35-40 minutes to do. You can go home the next morning and sometimes the same day. And for 98% of people, that fixes the acid reflux for the rest of their life. And those are some of the things that we were talking about. So if you compare lifetime medication with this procedure, where we've wrapped part of the stomach around the esophagus to recreate that valve that prevents the acid from going up. So here you see 21 million people are on proton pump inhibitors, which are the medications like omeprazole. 40% are still symptomatic, and there's concern about long-term risks of this medications. Compare it with surgery, where less than 1% are symptomatic, and the concern may be that whether this will last more than 15-20 years. If it doesn't, then we can redo it in 15-20 years. So those are the two options. Anyway, proton pump inhibitors really are not the solution for reflux, because they don't stop reflux, like I said, because patients still continue. It's an anatomical problem, and it needs an anatomical solution, which means a mechanical problem and a mechanical solution. Okay, so if you continue to experience symptoms while taking medication, then you should consider surgical options. If it's still negatively impacting your quality of life, then you should consider surgical options. And if there's concern about the risks of long-term medication, and you want to be free from medication, or you're concerned about the complications, then it's time to treat the problem and not mask the symptoms. Okay, so what is the incremental approach for this condition? So it starts with mild to severe GERD. If it's mild, you just do lifestyle changes. If it's occasional, then you can take proton pump inhibitors just temporarily. But if you're taking it every day and you're still refluxing, then you need to go on and consider other things. And there's a gradation here. The first thing here is LINX, which you can see. LINX is a procedure that is relatively new in this field. It's and I'll show you what it is. But basically, it's a band made of magnetic beads. Okay, so it's like a ring of magnetic beads that we can place in the upper part of the stomach and lower part of the esophagus, so that it creates this valve, and then we can create the valve laparoscopically or robotically. It's called fundoplication. So who are candidates for this surgery, as well as for placement of the magnetic beads? Anyone who is continuing to need medication for acid reflux and is uncomfortable with the side effects and long-term use of it, or is continuing to regurgitate. That means acid, or not necessarily acid, but just secretions are still coming up in spite of the medication. Looks like they're 30 minutes into it. Okay. Any questions so far? Should I, Emily, or should we just leave the questions for the end?
It's up to you. We end up getting a good amount of questions, so maybe we leave them for the end.
No, I'm good. I'm good with answering some.
Okay, sure.
Because I think it gives me and them a break,
Perfect. So why don't we see what we have here? So can you treat acid reflux without depending upon the dreadfully limiting diet?
Can you treat acid reflux without depending upon the dreadfully limiting diet? Well, only if the acid reflux is because of a weak lower esophageal sphincter, like I explained, which it almost always is, then yes. I mean, if you have minimally invasive surgery for it, that means the small, surgery. If you have a hiatal hernia and we fix your hiatal hernia, then you won't have to be limited in your diet. So a lot of it is what's going on. I'd like to do an endoscopy on you and see if you have a hiatal hernia. If you have a hiatal hernia, then I would just fix that hiatal hernia and recreate your valve. Then you could just be on a regular diet. You wouldn't have to be limited in your diet. I eat chocolate every day, for example. I eat dark chocolate every night. I don't get acid reflux, so it's not, but I know there are people who cannot eat it. I drink many cups of coffee every day and I'm fine with it. So yes, you can.
All right, great.
Fix
So
the problem, yeah.
One more here. Is hoarseness another symptom of GERD?
Absolutely. Hoarseness is a symptom of GERD in many, many cases. It's not the only cause of hoarseness though, because so once you have hoarseness, then it's important to be seen by your ENT or otolaryngologist so that they can check your vocal cord. Because sometimes hoarseness is a early sign of laryngeal cancer as well, so you don't want to miss that. But if everything else is negative, then it's most likely from what we call laryngopharyngeal reflux, which means the acid is going and irritating the larynx. Especially if the hoarseness is intermittent, that means it's there one day and then it's gone the next day. Then those are usually related to acid reflux. And fixing the acid reflux will fix the problem. That doesn't mean taking the medication will. You have to really fix the acid reflux, for which, like I discussed, and I'm sure you more of.
Okay,
All
great.
right,
And
so,
do you want to just take one more? I think it
yeah,
just has to
sure.
do with one of your other slides.
Yes.
How is long-term use defined, I think, in regards to medication, I'm assuming?
Yes, that's a very good question. And there's no hard and fast definition of long-term use. But certainly, if you're using it more than a year or two, then I think most people will agree that that's long-term,
Okay, great. And we've got more questions here, but why don't you continue on and we could take these at the end.
Okay, so the goal of surgical treatment for acid reflux is really to fix the problem. Like I said, it's an anatomical problem or a mechanical problem, and it needs a mechanical fix. It doesn't need to be masked with proton pump inhibitors or medications that make you still reflux, but you're just not aware of it or less aware of it. You see, so we actually resolve the symptoms rather than we control regurgitation. It improves quality of life and it eliminates dependence on medication. So what is the modern treatment for significant GERD? Now, obviously, if you have acid reflux, once a month or twice a month, then I don't think that anything needs to be done, But if you have significant acid reflux, then there are laparoscopic and robotic options that have revolutionized the management of this disease. And one of the newer things that we have is what's called the LINX procedure, which is magnetic sphincter augmentation. This can be done laparoscopically or robotically. And now just a little bit of introduction to the robot. We have 3 robots here at Mather now. We're right on top of the robotic surgery in the entire Northwell system. We were looking at the numbers and we were looking at the types of procedures that the other hospitals of the Northwell system perform robotically. And we're right on top, both in terms of state of art as well as the number of procedures we're doing, as well as our utilization of the robot. It was actually more than any other hospital in terms of utilization. So we have 3 robots, they stay pretty busy. The robot doesn't do the surgery, the first thing we want to point out. So who does the surgery? The surgery is being done by the surgeon. So what does the robot do? Well, the robot is like a puppet. It's being controlled from outside by the surgeon. So this in the middle is the eye of the robot. And that is, in fact, Emily, just for the thing, I think I should do a talk on robotic surgery. I'm also the director of robotic surgery here. And if you want to write it down and ask Nancy Uzo to do that, because I think that there's a lot for the community needs to learn about robotic surgery. But in a nutshell, that's the eye of the robot. And those are the little fingers that they're more like hands. So first we make the small little holes and we can put this through those small holes into the patient's abdomen. And then I sit at the console here. When I'm looking in this box, I can see inside the patient's belly. And when I move my hands, those movements are happening inside the patient's belly. And I've done more than 2,300 robotic operations. We've had very good results. And we do the Nissen fundoplication robotically. We also do it laparoscopically. It takes about 45 minutes to an hour. We usually keep the patient overnight. And for 94% of people, it causes long-term, which means at least 5 years, more than 94, 98% resolution, complete resolution of symptoms. This is an example of a case that I'm doing. I want to show you the video. I'm doing this laparoscopically. You can see this hole in the middle. That's the hiatal hernia. That is the stomach here, and the stomach is pushing into the chest. And that, the chocolate colored thing is your liver. And here we're repairing. What we're repairing is this hole, because no amount of medication will close that hole. That's what's allowing the acid to go into your chest. You see? So we're going to bring this down, and that's actually me performing a laparoscopic repair of a hiatal hernia and what I call fundoplication, which is something we do for acid reflux. most patients with acid reflux do have a hiatal hernia, which is contributing or causing their acid reflux. And that is part of the diaphragm there. It's called the left cruce of the diaphragm. And here we are separating some important vessels here. That is the spleen. We're separating the stomach from the spleen there. And see, once we freed it up, then we can fix it. That's the esophagus. That's where it had gone into the chest, which is called the hiatal hernia. That's the heart beating in the background. You can see it. That's the liver. And there's a nerve there called the vagus nerve, which we have to identify and preserve. Here we've pulled the esophagus or the food tube down. You see this big hole? That's what's causing the acid reflux. So we are going to close this. See, this is an instrument I use. It's called the endostitch. I use this when I'm doing this laparoscopically because I can't put my whole hand in there, but I can do the stitching using this instrument. See how it's closed that hole? Now that prevents the acid from going up. That's your heart beating up there. This is the esophagus. And now I'm going to do what's called a fundoplication, which means I'm going to make a new valve. And here I'm taking part of the stomach and wrapping it around the esophagus. See, this is the esophagus, and that's the wrap of which you're making. It's the part of the stomach that we're going to create. And here we are stitching it around that. That prevents acid from going up. You don't need medication. And like the person who asked the question asked, can you eat regular food? You can eat regular food. You can eat any amount of, chocolates and caffeine and tomatoes-based things that cause acid reflux. There'll be no acid reflux after this because the acid, God made acid for a reason. It was to help you digest your food, So it's not in order to suppress it with proton pump inhibitors. It's just that the problem is it was not going in the right place. It was going up. Okay. So obviously, there are advantages and disadvantages of surgery, but then the links, which is the magnetic acid, reduction procedure. These are made of magnets, these beads, and we place this in the lower part of the esophagus, junction between lower esophagus and upper stomach, which is called the lower esophageal sphincter. It makes the sphincter tighter. That's why we call it sphincter augmentation with the help of a magnet. So it prevents the acid from going up. And it's dynamic. See, it's placed here in the lower part of the esophagus and the upper part of the stomach. And when the food has to go through, then it opens and allows the food to go through, but it doesn't allow the acid to go up. You can see when the bolus of food is coming, it opens up. But when the bolus has gone through, it stays closed. So no acid can go up. See this? The acid is the green one. It's going down. So you don't have to suppress it with medication. And you can eat normally. I'm going to show you a video of me doing a links procedure. What happened?
Let's go back.
Yeah, let me see if I can show you that video. Yes. So it's just a short, we'll just show you that particular part. Is it coming?
Yeah.
Okay, it will come. Just be patient. So that's me separating something called, that's the diaphragm. And those are some, attachments in that area. We call it the gastroesophageal, attachments or phrenoesophageal ligament. And then we divide that ligament there. And then we can find a place through which we have to introduce this. And that's the right cruce of the diaphragm. And we are going to be going behind the esophagus and the stomach over there and in front of the right cruce of the diaphragm. And then we place this thing that I'm using now is called a sizer. It tells me what size of, magnetic beads to use. Once I've determined the size, then these are the beads. They're like a bracelet. You take it like a bracelet, and just like you put a bracelet around your wrist, I can put this around the lower esophagus. And then I just have to close the bracelet, and it just clicks close. And that's easy. So that's why this makes the operation a lot easier. It's like putting my Cassandra, who's our secretary, she's saying, wow, even I can do that. So it isn't a difficult operation, to do that. But if you look at quality of life, after placing this magnetic sphincter, then you find 5 years later, the majority of patients have a much, much better quality of life. And if you compare, using the sphincter or the magnetic beads with the traditional operation, then it depends. I personally, I do a very good traditional operation, so I actually like the traditional operation a lot. There are many patients who, on the other hand, they prefer to have the magnetic beads. And there are other things that can be done. I actually first introduced this more than 20 years ago in Long Island. We did the first ones of the Strata procedure, but it's not as effective. So I'm not a big fan of it because I don't think that's effective, but I just mention it because you might have heard of it. And then there are other ways of doing this all endoscopically. That means going through your mouth and do it. And we are certified to do these. However, we don't recommend them because most patients have a hiatal hernia. So the company that makes it says, do the operation first, fix the hiatal hernia, and then do this in this fashion. But if I'm doing the operation anyway to fix the hiatal hernia, I might as well complete the whole thing, So that's why I'm not a big fan of that. And which bird is that?
It was just the questions. One
Oh,
of
it's
those
a
questions.
All right, questions. This is the state bird of New York. You know which bird that is?
Is it
All right,
the,
great.
oh, that's a bluebird? No, robin, redbreast. No?
No, it's not a robin redbreast.
What is it, a blue-
Eastern bluebird. You're right.
Bluebird, there you
Okay.
go, bluebird, there you
All
go.
right, great. Okay, so we have a lot of bird questions here. So any questions?
Let me
15 minutes for questions.
see. Can a person who has acid reflux just have a cough without any other symptoms?
Yes, they can. So if somebody has a cough with no other symptoms, then we need to figure out why they're having this cough. And if they find something from the pulmonary point of view, like in the chest x-ray, etc., or the chest doctor finds a reason for the cough, then that's great. Then that's the cause of the cough. If, on the other hand, they don't find anything, then it's very likely that it's coming from either an allergy or from acid reflux.
My LES was inactivated by Heller myotomy surgery. Does that mean surgery not an option for my reflux?
Yes, now that's a difficult one because if you've had Heller myotomy, and I do that myself, the Heller myotomy, it means that your problem was that the lower esophageal sphincter was not relaxing. That means it was always staying in a contracted state. So then we had to cut it. You see, so now that we've had to cut it, if we try to do surgery to make that sphincter effective again, then you'll have trouble swallowing. So it depends on your motility, but most likely, I don't think that in your case, we can do any surgery to help you. You'll have to live with reflux, unfortunately. Now, there are things we could try, but none of them have been accepted here.
What does it mean that I burp frequently, really big, long burps?
Okay, when you burp frequently, big, long burps, it just means you're swallowing air. It's not a disease in general, okay? So most people that come and say, our problem is we just burp all the time. Does it mean we have acid reflux? Not necessarily, most likely it's just that you're swallowing air. That's something people do unconsciously and something that you can't really change. On the other hand, there are people who have acid reflux and they're burping as a result of that. So one way to figure this out was if it's really severe and it's a big problem, then it's good to have an endoscopy and see whether there's anything going on. An endoscopy only takes 3-4 minutes, it's not a big thing.
How long should you use PPIs before you consider surgery?
So I don't think that there's a definite length of time that you should use PPIs before you. I would certainly think that if you're comfortable with using PPIs for the rest of your life, aware of all those side effects, then then I think that you can, and you're scared of surgery or you're a very high risk for surgery, then you can continue for the rest of your life. If on the other hand, you're not a high risk for surgery, which means you're otherwise reasonably healthy and you're open to having surgery, then I don't think that has to be a minimum length of time. On an average, most people have had it for a year or two before they consider surgery.
If acid reflux happens once a month, should surgery be considered?
No, I think if acid reflux happens once a month, then I think that it's less likely that you would need surgery. So let's start with trying to assess, how you do just with Tums, and maybe take it just once a month. If you take your proton pump inhibitors, once or twice a month, then that's not a bad thing. I think in those patients, I would just recommend not having surgery.
Can nausea be mild with acid reflux?
Nausea is not usually a feature of acid reflux. In some people, it can cause acid reflux, but in general, it's not a feature. So to answer your question, can it be mild? Yes, it can.
Is the type of food related to acid reflux?
Yes, there are various foods that reduce the strength of the lower esophageal sphincter, which means they make it relax. And these are things like caffeine and chocolate and things like that, sometimes fatty food. It makes that lower esophageal sphincter relax more easily. And that allows the acid to go up from the stomach into the esophagus.
I'm not overweight, but I do have a hiatal hernia. How could that be possible?
That is possible. I do a lot of patients I do surgeries on, and they have a hiatal hernia without being overweight. So being overweight increases the chance of having a hiatal hernia, but a lot of skinny people have hiatal hernias that need to be fixed, and many of them have big hiatal hernias.
Do the magnetic beads, ever break free, and what are the risks if they do?
Yeah, they do not break free, so there would be no cases where the magnetic beads have broken free, but they can rarely, less than 0.1% of the time in all the studies that have been done, have they eroded. That means they've tried to go inside the esophagus instead of staying outside them. So when that happens, then we have to remove them, which can be done laparoscopically.
Magnetic sphincter of beads, purpose of magnetism.
The purpose of the magnets is to hold the sphincter, to hold the beads together, so that it's almost like an elastic band, so that at times it separates when food comes through, but then it comes back again together.
If I get relief by not eating 3 hours before sleeping and sleeping on a slant, am I addressing the problem?
Yes, so the basic thing is there are two problems, and this is for everyone who's hearing. There are two problems that you have to address here. The main problem that you have to address is not the feeling of burning or acid reflux or heartburn, as people think that's the main problem. But the main problem is the regurgitation. And the second problem is the burning of the esophagus or the heartburn. So regurgitation is where fluid is coming into your lungs or moving up from your stomach into your food tube or esophagus and then going into the larynx and the lungs. That problem can be completely addressed just by keeping the head end of the bed up and eating much earlier, before going to bed. So if that problem is resolved, then you are addressing the problem and you're not needing proton pump inhibitors. That means, omeprazole and other medicines, and you're fine with just eating, well ahead of your sleeping time, and you're not using medication, then I think that's for patients like that, they don't need to do surgery.
I cough after every meal, and at night, even with my bed inclined, I turn over to my left side and I wake up coughing. I've used PPI, but I still had the cough. All the PPI did was cause diarrhea, and I've been coughing now for years. I'm not overweight, and I watch what I eat.
Yes, you're a perfect candidate for this if you're otherwise healthy, because I'd like to see you. I'll do an endoscopy if it's not been done already. You probably have a hiatal hernia. And I think that your problem is we need to fix the hiatal hernia, and we'll do a fundoplication for you.
Are there any long-term negative side effects of the surgery?
There are no long-term negative side effects, except, one of the effects of the surgery is that It increases the amount of air you swallow, because before you were swallowing air and then it was coming out as a burp. Now it doesn't come out as easily as a burp, so you pass it down from the bottom more. But this, so you may pass more gas, but it doesn't smell or anything as much, but it just is more, the amount of gas can increase in many patients, not everybody. When we use the sphincter, the magnetic sphincter, then that is less likely to happen. Now, there are some things that can happen in some people, but they're not long-term side effects. And those are like temporary things. Like, in the beginning, there can be some difficulty in swallowing things that are very hard in consistency. You may have some trouble swallowing them early on. But in a month or 2 months, that should be resolved in most patients.
What type of anesthesia is used?
General anesthesia.
This is a good one. What is the best way to contact your office?
Best way to contact my office, you could either go through Mathers, whatever site has been set up for this, or you could call my phone number, 631-689-0220. Or you could just go to Mathers site where they put the number for this. I think Emily knows that, right?
Yeah, absolutely. And we send out an email to all the attendees to complete a brief survey, just so, Dr. Ahmad can have feedback. And in that email, I can include the phone number to make an appointment with him.
Perfect.
And we have a couple more here.
Yeah,
I'm
sure.
on PPI drugs. What diet advice for me to minimize the risks from the PPI?
I'm not aware of any diet advice to minimize the risks from the PPI. So just to put things in perspective, I generally don't treat my patients long-term with PPIs, unless if I have to. And I don't give them any advice about not eating anything in particular to avoid side effects of PPIs.
If I skip one day of my Acifex, my acid reflux is unbearable. I have a hiatal hernia. I've been taking my meds for about 10 years. Am I safe?
You are a perfect candidate for this surgery. There's no reason for you to continue to suffer or continue to take this medication. At least you should be aware of the surgical options. So you should come and see me, and I would love to help you.
Can postnasal drip be allergies or acid reflux? How do I know which is what?
And that is a very good question, because sometimes people think they have acid reflux, but they actually have postnasal drip, So one way to tell whether somebody really has acid reflux, so firstly, you'll have an ENT doctor examine to see whether you have postnasal drip. Very often they can tell you based on the examination of your, oropharynx. But if they can't tell and they're not sure what it is, then one way to tell whether you have acid reflux or not is what we call a Bravo. So when we do the endoscopy, we can leave a little capsule in the esophagus, and it communicates by Bluetooth to a beeper that you're carrying, and it passes that information about how much acid was coming up at what time. So then we can look at that graph for 24 hours, and we can say whether you're actually refluxing acid or not. If you're actually refluxing acid, then it's acid reflux. If you're not refluxing acid and you're having that symptom, then it most likely is postnasal drip.
Okay, great. We'll give it another 30 seconds. If anybody has any other questions, please feel free to enter them now. Dr. Ahmad is on fire.
Yes.
All right. In the meantime, you guys will get an email, Dr. Ahmad, if that's all right, with that phone number to make an appointment.
Sure.
And a link to view the recording after Dr. Ahmad sees it. Give it another few seconds here. Otherwise, everybody, please just enjoy your day. Dr. Ahmad, thank you so much for your time here with us.
Like I said, Emily, I always like doing these presentations. I love to explain things to people. And
great. We'll have to schedule you for a robotic surgery.
yes,
So
robotic
stay tuned for that.
I'm also the director of robotic, like I said, in addition to bariatric. And I think robotic is something patients really would like to know about, because it's a very unknown kind of a thing. Thank you, Emily.
So good. We actually just have
everyone.
2 more that just popped up.
Okay.
What is the name of that test that you just mentioned for differentiating reflux from postnasal drip?
It's called a Bravo, BRAVO.
Great. And could you just explain the use of anesthesia?
For the surgery, we use general anesthesia. So that means that, the patient's completely asleep. And you don't know anything while this is being done. So you wake up and it's already done, The procedure, the endoscopies are not done under general. I mean, they're calling it general, but it's really just an injection that they give you so that you're like in another world. It's twilight. but the surgeries themselves are done under general anesthesia. And the reason why, if I explain you, if you mean why we are using it, is because we fill the belly up with this air, which is carbon dioxide, and then your body absorbs it, or we let the carbon dioxide out. But in order for it to give us enough space to work, the muscles have to be completely relaxed. So that's why we use general anesthesia.
Okay, great. And I think that just about wraps us up. Thank you again, Dr. Mott, and everybody enjoy the rest of your day.
Pleasure. All right, take care, you too. All right.